Thank you again joining us for this afternoon session, looking at first two cases that will be presented by Dr. Arifuddin on patients with chronic hepatitis B who also has concomitant fatty liver disease. And we will actually have an overview on this topic on MAFLD or MASLD. The reason for the name change recently will be the focus of the discussion too. And I will end with highlighting the impact of steatosis in patients with chronic hepatitis B. So let's go ahead and get Dr. Arifuddin to share his slides and present the two cases. A very short discussion because the bulk of the discussion will be covered during the overview and the last part of the presentation. So go ahead, Dr. Arifuddin. Are you able to share screen now? Why am I not getting through to you, Dr. Arifuddin? Hang on. I'll call you again.
Hello, everyone.
Yeah, go ahead.
Hello, can everyone hear
Yes,
me?
we can hear you. We can hear you very well.
So today I'm going to be presenting a topic on approach to MAFLD, which is the acronym for metabolic dysfunction associated fatty liver disease. So before I start presenting, this is the outline of my presentation today. There is cases of chronic Hep B with MAFLD, burden of MAFLD, natural history of MAFLD, diagnosis, management, take-home messages, and references. So let us start with a simple case presentation. First case is a 34 years old Malay gentleman with underlying chronic hepatitis B with fatty liver disease in 2019. He is on entecavir. His HBE antigen is non-reactive with positive anti-HBE. The DNA PCR in 2022 is less than 10. The fibroscan that was done in 2019 shows LSM of 7.7 kilopascal with a CAP of 306. Ultrasound HBS shows grade 2 hepatosteatosis. He also has underlying diabetes with HbA1c of 9.5 on OHA. He denies taking traditional medication. However, during the TCA review, noted there is increasing of ALT. Otherwise, it's normal. So here we can see, I just want to show that during the appointment, the TCA in 2022 to 2023, we can see there is increment of the ALT level from 80 to around 110. Then we see him in our, and then also noted the HbA1c was high at 9.5%. And then during the TCA in clinic, during this time in September, we counseled this patient for we started him on subcut insulatard to control his diabetes and also advised him for weight reduction. And luckily, he managed to lose weight during the fasting period. And during the next appointment in 29th of April, we can see that there is improvement of his ALT level and along with his HbA1c from 9.5 to 6.4%. Second case is a case of 83 years old Chinese gentleman with underlying hypertension and dyslipidemia. He has also chronic hepatitis B on tenofovir since 2014 with HBV DNA in 2017 was not detected. The HBAG is negative, the anti-HB is positive. Latest ultrasound HBS in August showing liver cirrhosis. There's no focal liver lesion. This patient noted to have liver cirrhosis from ultrasound starting from 2022. Before that, there's only hepatic steatosis. The latest HBVD and APCR repeated this year, not detected in patient complying to his intercavir. Otherwise, his platelet count is always on the normal side. His normal LFT, we can see LFT is normal. The platelet count is also normal. The TG is slightly raised and the BMI is slightly obese with BMI of 32. So we advise this patient for weight reduction and arrange is the question is fluorescein be useful for in this kind of case of where this patient having chronic hepatitis B and also the liver having hepatic cirrhosis with high TG. So fluorescein would be useful in this kind of case.
Okay.
So what is the impact of steatosis in patients with chronic Hep B? This one will be further discussed by Prof. Rose. So I just want to give
Hang on.
a
Let me
bit
go back
of
to the case.
insight and introduction to
Sorry, Dr.
the
Arifuddin.
current nomenclature that has been used for the definition of the MAFLD. So the first term is used in 1980 by the Ludwig J. A.L. in 1980 as he define the first term of non-alcoholic fatty liver disease as is a liver condition mimicking alcoholic hepatitis that can progress to cirrhosis with no significant alcohol intake. So this is the first term we use, non-alcoholic fatty liver disease. And then later in 2020, this term had been changed to MAFLD, which is metabolic dysfunction associated fatty liver disease. Was endorsed by the Asian Pacific Association for the Study of the Liver in their CPG in 2020. The major benefit of this nomenclature is a shift to a diagnosis of inclusion based on the presence of metabolic dysfunction, which is the key driver of this disease. And the new diagnostic algorithm developed from positive criteria regardless of alcohol consumption or other concomitant liver disease. So then latest in 2023, there is a new point term, which is the MASLD, which is metabolic dysfunction associated steatotic liver disease. So this is like a term to encompass various etiologies of steatosis. Because the term of NAFLD, non-alcoholic fatty liver disease, is widely used, it has always been appreciated term non-alcoholic did not accurately capture the etiology of the disease, and the term fatty has been stigmatizing to some. So that's why they shift from the term of non-alcoholic fatty liver disease to MAFLD, and now is the MASLD. So in 2023, there is a modified Delphi process for which there is a consensus made by this independent review, for which they came with the nomenclature of MASLD, metabolic dysfunction associated steatotic liver disease. So the new nomenclature and diagnostic criteria are widely supported, non-stigmatizing, and can improve awareness and patient identification. Those with no metabolic parameters and no known cause were deemed to have cryptogenic steatotic liver disease, and a new category outside the pure MASLD term MET-ALD, which is the combination of which is defined as MASLD with greater alcohol consumption to describe those with MASLD with alcohol consumption of greater than 140 to 350 gram per week and 220 to 420 gram per week for females and males respectively. So this is the summary of the new nomenclature that we use, which encompass the steatotic liver disease. So basically, under steatotic liver disease, we have the metabolic dysfunction associated steatotic liver disease (MASLD), the MET-ALD, for which I have defined earlier. We have the alcohol associated liver disease, and also specific etiology of steatotic liver disease, which is DILI, miscellaneous, and also there is also cryptogenic steatotic liver disease. So basically, the consensus changed the definition to include the presence of at least one of the 5 cardiometabolic risk factors. So the algorithm for which we define this patient to have this MAFLD. So from the imaging or biopsy, when the patient having steatotic liver disease, and then does the patient meet any of the cardiometabolic criteria? And then if there is the patient meets this criteria, whether there is any other causes of steatosis. If there is no, then this patient will encompass as MASLD. If it is yes, then MET-ALD or other combination etiology. And if the patient doesn't meet the criteria of cardiometabolic, so we will define them as cryptogenic steatotic liver disease. This is the cardiometabolic criteria that I mentioned just now. So basically, if the patient having imaging or biopsy suggestive of steatotic liver disease with one of these 5 criteria, we will define them as having metabolic MASLD. Basically, BMI more than 25 or West circumference more than 94 cm. But then this one need to be ethnicity adjusted on the locality. The fasting serum glucose of more than 4.6 or 2 hour postprandial glucose more than 7.8 or HbA1c more than 5.7 or type 2 DM on treatment or not. BP or blood pressure of more than 130/85 or is the patient on treatment. Plasma triglyceride of more than 1.7 and plasma HDL less than 1.0. So this is the cardiometabolic criteria. And if the patient having one of these 5 criteria with the imaging of steatosis, you will find them as having MASLD. So the key metabolic dysfunction underlying this MASLD is insulin resistance, and selected metabolic risk factors do not equally predict insulin resistance. As for example, the blood pressure and HDL are only weakly associated with insulin resistance. However, insulin resistance and steatosis may be present in the absence of any cardiometabolic risk factors, especially in younger adults in the primary care setting. Now I kind of talk locally in Malaysia. So in Malaysia, basically, this is based on the APSL 2020. So the burden of MFD is still a principal worldwide causes of liver disease and affect nearly quarter of the global population. And NASH, non-alcoholic steatohepatitis, demonstrated greatest increase and become the second leading etiology of chronic liver disease among the new liver transplant registration in the US. So in Malaysia, we can see that there is 1 in 2 adults in Malaysia is overweight or obese. So diabetes in Malaysia also quite prevalent, with 1 in 5 having diabetes and 1 in 4 is physically not active. So, and also the Malaysians have a tendency of having a lot of sugar in our diets, especially. So we can expect the local prevalence is estimated to be 20 to 40% based on these 2 studies published today. So basically, the prevalence of MAFLD is quite significant worldwide. The natural history of MAFLD, basically, the annual incidence of MAFLD is around 3 to 4%. And then when in normal liver, there is absence of cirrhosis. Then 25% progress from simple steatosis to steatohepatitis and have fibrosis progression in 3 years. And then this steatosis can further develop and cause fibrosis. And this fibrosis can further develop to cirrhosis. And around 1 to 4% of patients with cirrhosis can develop HCC. So this is the diagnosis of MAFLD. Later I will put like some difference between the diagnosis of MAFLD and the MASLD. Basically, MAFLD it's the finding of hepatic steatosis, whether on imaging or non-invasive scoring or histology, plus whether the patient is overweight or obese, defined as BMI more than 23 in Asians, or having type 2 DM, or presence of more than 2 metabolic risk abnormalities, which is almost the same like the MASLD criteria, which is for Asian, it is the waist circumference is more than 90 cm for men. Others are about the same with the MASLD criteria. So here is I put the diagnosis of how we diagnose the difference how we diagnose MAFLD and MASLD. So we can see here MAFLD, the diagnosis is whether the patient having either overweight or obese, or having type 2 DM, or if the patient is of the normal weight, having at least 2 risk abnormalities. So we will see this patient having MAFLD. While MASLD, metabolic associated celiac liver disease, there is only need of only one criteria present from this, which is actually about the same with MAFLD. So the management of MAFLD, basically we will reach the patient of having fibrosis or not. So there are a few markers that is used, either aggressive biochemical biomarkers such as FIB-4, and also there is also fibroscan and liver stiffness assessment. So based on this risk assessment, we will certify this patient whether having low risk or intermediate and high risk. For low risk patient, we will repeat the non-invasive test at 2 to 3 weeks time. While if the patient having fibrosis from this non-invasive test, evidence of fibrosis, so we would this patient will be referred to specialist referral and consider liver biopsy to assess fibrosis state, and also assess whether the patient having liver cirrhosis. And some of the therapeutic options that can be done to the patient is lifestyle modification, metabolic risk assessment of the cause, diabetes, hypertension, dyslipidemia. The pharmacological approach for metabolic associated fatty liver disease is still yet need to further study, such as currently the medication that has been approved so far is vitamin A and pioglitazone. So we always need to check the BMI or waist circumference for the patients. So the BMI for the Asian adults, lean is 18.5 to 22.9, overweight is BMI of 23 to 24.9, obesity is if the BMI more than 25. Central obesity defines by waist circumference more than 90 cm in males and more than 80 cm in females. And also, we also need to check patient of having diabetes, as up to 70 patients with type 2 DM actually having this MAFLD or MASLD. Check for presence of metabolic risk abnormalities. So this is the cardiometabolic risk factors that I mentioned just now. So basically, this is the markers that we need to control in this patient, in the patient with having MAFLD and MASLD. And the most important thing, what we need to do is to certify this patient as having fibrosis or cirrhosis or not. And the hepatic fibrosis biomarkers can be done by a few tests such as the FIB-4 score, fibrosis 4 score, enhanced liver fibrosis, NAFLD fibrosis score, and fibro test. Liver stiffness assessment can be done through fibroscan, supersonic shear imaging, APRI, acoustic radiation force impulse imaging, and also MRE, magnetic resonance elastography. So all of these are a few tests that we can do to assess fibrosis in patients. Why do we check for advanced fibrosis? Because stage of fibrosis is the single most important predictor of liver-related death. So as we can see here, if the fibrosis, we can see the ratio significantly increase when the fibrosis stage is 4. And it proportionately increase with the increment of the fibrosis stage itself. So FIB-4 score is the simplest and easiest test that we can do to assess the fibrosis in this patient. So cutoff value of less than 1.3 has a high negative predictive value of 94.3% to exclude having advanced fibrosis. However, we need to also need to acknowledge that there is the specificity of FIB-4 score is lower in patients more than 65 years old, resulting in higher false positive rate. Therefore, higher cutoff for low risk, i.e. FIB-4 score less than 2, may be used to exclude advanced liver fibrosis for patients more than 65 years old. So, we would say that for patients to develop advanced fibrosis, if the FIB-4 score is less than 1.3, the risk of fibrosis is low. And if the patient is more than 65 years old, we will use the score less than 2.0 to say that there is low risk of fibrosis. Fibroscan is one of the non-invasive tests to measure the liver fibrosis. The patients need to fast about 2 to 3 hours prior to the scan. It is so basically Fibroscan will measure two parameters, which is the liver stiffness measurement, LSM, and also CAP, the control attenuation parameter. So what's the comparison of the characteristic of FIB-4 and the transient elastography? So basically, the FIB-4 score is, of course, it is cheaper and easier to do, and it is widely available. Otherwise, the accuracy of Fibroscan is, of course, higher, but then of course the limited availability is the limitation for us to do in our patient. So once we have assessed this FIB-4 index, FIB-4 index, so we will certify the patient. If the FIB-4 index is less than 1.3, unlikely to have advanced liver fibrosis, and we can repeat this in about 2 to 3 years. And if it is more than 1.3, we see the liver stiffness measurement. If it is less than 10, unlikely to have advanced liver fibrosis. If it is intermediate, 10 to 15, may have advanced liver fibrosis, and this need to be monitored about yearly. And the fibrosis, if the LSM is more than 50, likely to have advanced liver fibrosis, and we need to consider surveillance. And if it is more than 20, likely to have clinically significant portal hypertension, and this patient, of course, need his surveillance with brazil screening. And then in the patient attending primary care clinic, we assess the patient using Framingham score and assess this patient having diabetes. And we after we screen this, we screen for MAFLD using ultrasound, and we will if the patient have MAFLD, we will screen them to do the FIB-4 score. And if it is the index is more than 1.3, which having which have the possibility of having liver fibrosis, so we need to do further assessment for this patient. role of liver biopsy in MAFLD. The indication for liver biopsy with suspected MAFLD is when we uncertain of the diagnosis and evaluation of dual etiologies. Sometimes this can happen in patient having autoimmune hepatitis, for which the transaminitis we're not sure either due to autoimmune hepatitis or MAFLD. Non-invasive tests show indeterminate or non-concordant result during cholecystectomy and bariatric surgery and for research purposes. So basically, the role of liver biopsy is really not indicated if we certain the diagnosis of MAFLD. However, if we uncertain of the cause of the liver fibrosis or the liver cirrhosis or the transaminitis, what is the cause of the etiology? So we might consider the liver biopsy to determine the cause. Otherwise, the treatment for MAFLD is still much towards non-pharmacological, which is lifestyle intervention, especially for which we will advise the patient for weight loss, exercise, and also dietary modification. Pharmacotherapy, there is still no FDA-approved medication for MAFLD. Surgical, bariatric surgery in selected case for weight reduction. For patient with MAFLD, we would advise them to lose around 7 to 10% of their weight, and then we can see the improvement of the liver enzymes and the histology. Gradual weight loss up to 1 kg per week is recommended with hypocaloric diet of 500 to 1000 kilocalorie deficit per day. So why we advise this patient to having about 7 to 10% weight loss to our patients. So basically, from the study that was done, we can see that when the weight loss is more than 7%, more than 10%, we can see there is the NASH resolution and also fibrosis resolution. So the result of weight loss to the patient's fibrosis and inflammation had improved a lot when they lose their weight. Dietary intervention, Mediterranean type diet is advisable. More recently, small-scale randomized studies have demonstrated beneficial effects of intermittent fasting as well. Exercise, we will advise the patient to have moderate intensity exercise of 30 minutes per day. So this will help in basically help in reducing the visceral fat, for which will help in reducing the steatosis in the liver. So the pharmacological treatment for MAFLD, so far it hasn't been approved by FDA. However, some of the recommendation provided by the Malaysian Society of Gastroenterology and Hepatology, some of the pharmacological treatment that can be advised to patients, such as pioglitazone, vitamin E, as vitamin E at dose of 800 units per day, which, however, it is associated with increased risk of prostate cancer and hemorrhagic stroke. And it's still, the level of recommendation is still low, actually. While management of metabolic risk factors to reduce the CVS risk, statin should be initiated in patients with MAFLD who meet criteria based on current recommendations. So basically, not every patient with MAFLD need to be on statin, actually. So it's still based on the local guideline with the using the Framingham risk score, and also whether this patient has others comorbidities that accounted for. Otherwise, ACE inhibitor and ARB is the preferred first-line antihypertensive for patients with MAFLD with strong recommendation. The new studies that have came, such as SGLT2 and GLP-1 for the management of patients with MAFLD have been positive so far. So far, the latest guideline didn't specifically mention regarding the use of SGLT2 and GLP-1, but otherwise, the study have demonstrated a good prognosis so far, a good outcome. Metformin also, it doesn't show to improve steatohepatitis. It can lead to improvement in metabolic parameters in the patients with diabetes. And once the diabetes is controlled, usually the fibrosis of the MAFLD will also be improved. Role of bariatric surgery. Bariatric surgery should be considered in a patient with MAFLD when their BMI is more than 35 and failed lifestyle modification. The type of surgery of choice, Roots and wire gastric bypass, provide a greater positive impact with patients with MAFLD. So, in summary, MAFLD has become one of the major causes of liver cirrhosis, and it has been alarmingly become increasing. Lifestyle modification is the cornerstone of MAFLD management so far. Weight loss of more than 10% can lead to fibrosis improvement in almost half of the patients and NASH resolutions in 90% of them. There is no FDA-approved pharmacotherapy yet. However, some, of course, positive emerging evidence of using SGLT2 inhibitor and also GLP-1 that would shift these dynamic changes to the management of MAFLD. So this is my references for my presentation.
Okay, thank you very much, Dr. Arifuddin. I don't know whether you can hear me, but you can stop sharing your screen.
Of course.
Okay. All right. So thank you very much for that. So I'm just going to actually go back to the case because I think it's important for us to actually really, what are the lessons learned? So this is the second case that he showed. Hang on, let me just go back to the first case. So the first patient with chronic hepatitis B, a young man who actually has had treatment on entecavir since 2019. And you can see from the hepatitis B DNA, the virus is well suppressed with the DNA being undetected. And you can see also that he had a FibroScan, which showed that very high CAP score, which means to say there's severe cytosis at CAP of 306. But he also has significant fibrosis, and that is possibly related to hepatitis B itself. And with improvement, you can see from the next slide, with improvement of the diabetes, with the HbA1c dropping from 9.5 to 6.4, there's also improvement of his ALT, and hopefully that really reflects improvement also in the inflammatory activity within the liver. So for the second case, an older man, 83 years of age, again, on antiviral treatment, is done tenofovir for a long time with very good viral suppression, documented very recently too, also in 2017, with undetectable hepatitis B DNA. And yet, despite well-suppressed viral suppression, we actually can see from the ultrasound that he has progression in the sense that the liver on the ultrasound is suggestive of liver cirrhosis. I do not know the detail, what was found, but I presume that it's of course ecotexture and possibly even an irregular liver margin. But if you look at what could be the contributory causes, of course, his BMI is one of them, and perhaps his waist circumference is also high to reflect similar to the BMI. But he also has got another risk factor, which means that his triglyceride also needs to be controlled. And this is one of the things that I think is important for us to take note, that the progression that he had may be related to the metabolic dysfunction or the metabolic risk factors that he has. So let's now go to the actual studies to show what is the actual impact of MAFLD or steatosis in patients with chronic hepatitis B. So I'm going to stop sharing and try to get another part of my presentation. Hold on. So while waiting, are there any specific questions with regards to the case, or you can actually put your question in the chat, and I will also try to address some of these questions later on. But if you have any burning questions now, go ahead and unmute yourself. You can do that too. So let's look at the presentation on, this is from my ex-student who's actually now doing his master's in surgery. Now he was actually doing this research project as immediately after his MBBS while waiting for his housemanship, and actually completed his Master of Medical Science. So I will actually present some of his research data, and I've modified some of that to actually reflect a more recent data based on the publication. So what he looked at initially, even prior to the study, he actually looked at the prevalence, did a meta-analysis looking at the prevalence of fatty liver disease in patients with chronic hepatitis B within Asia. And he showed that the overall prevalence is actually quite high, 34.4%. And that time, there was no studies from Malaysia to suggest what our prevalence of hepatic steatosis is amongst patients with chronic hepatitis B. So his research question was mainly focused on what could be the potential effects of having the two diseases together. Could the steatosis or its related causes such as diabetes and the causes of metabolic risk factors have an impact on the progression of chronic hepatitis B? So again, there's very limited studies on this from our own, not just Malaysian data, but also in the region as well. So the objectives for that study was looking at first the prevalence of steatosis among patients with chronic hepatitis B. He also looked at the relationship between the steatosis and advanced fibrosis and or cirrhosis in patients with chronic hepatitis B, and looking at the overall impact of steatosis and or advanced fibrosis on outcomes such as cardiovascular events, liver-related complications, malignancy, and all-cause mortality, and the combinations of all these, what we actually term as the composite outcomes. So more than 600 consecutive chronic hepatitis patients who underwent transient elastography were recruited. Out of these, 578 had follow-up until the 31st July 2019 to look at the clinical events. So we stopped there because at the time, these patients had at least nearly 3 years of follow-up and some up to 5 years. So we could capture what are the events during the follow-up period. So one of the things that's really outstanding about this population is that in this 614, the median age, much older than some of the studies that have been done in this area. For example, here, we're looking at both patients who are treatment naive and also have been on antiviral treatment. The median age is 60 years, and there are 47% being males and 53% being females. And what is really outstanding, again, is the presence of steatosis in nearly half of our patients with chronic hepatitis B. And that's actually quite high compared to what I had shown earlier, that in this region, the studies showed that it was only about 34%, whereas for our study, it's nearly 50%. And again, important to note that the presence of advanced liver fibrosis amongst our patients is also quite high. 21% of patients had advanced fibrosis amongst these patients with chronic hepatitis B, and also most of them probably related to the presence of this steatosis. So this slide actually shows that amongst patients with steatosis, there's a lot more higher prevalence of having advanced liver fibrosis, regardless whether you are treatment naive or receiving antiviral treatment. So the next slide is very interesting, and this is not new. It is actually known for a while that when you have the two together, there are some studies to show that the steatosis itself may have a favorable effect on the viral load. So in these patients, these are looking at patients with chronic hepatitis B who were actually treatment naive. They were not on treatment, looking at what is the impact on the viral load. And you can see that the significant lower viral load in patients with severe steatosis compared to those without steatosis. And even comparing severe steatosis to mild steatosis, there's also a significant difference, a slightly lower viral load in those with severe steatosis compared to those with mild steatosis. And that has been really, a few studies have shown that this may be the steatosis-induced apoptosis that occur in these patients with hepatitis B that may impact on the viral replication and lower the viral replication rate in these patients. So just to summarize the first part of the study, that yes, steatosis is high, but also is an important independent factor to actually predict those with, who are likely to develop advanced liver fibrosis. But not only that, the other important independent factor associated with advanced liver fibrosis is also well known. The presence of diabetes is 3.5-fold higher risk of having advanced fibrosis if you have got diabetes plus chronic hepatitis B or diabetes relating to the fatty liver disease and also having chronic hepatitis B. And again, there's the other two, male gender also confer 1.7, 1.6 higher risks of having advanced fibrosis, and also the DNA. But note that among those on antiviral treatment, the same study showed that the longer duration of antiviral treatment in these patients with chronic hepatitis B who are receiving antiviral treatment is inversely related to the fibrosis stage, showing the well-suppressed antiviral treatment suggests that you can actually reduce your risk of having advanced liver fibrosis. And that's shown even in patients who have just chronic hepatitis B without MAFLD. Now looking at clinical outcomes. So these are outcomes after a median duration follow-up of 45 months, ranging from 32 months to 63 months in these patients. And you can see that the composite outcomes are actually higher. Oh, sorry, the composite outcomes are shown here. But what I would like to actually stress are the outcomes that we are showing here are very much outcomes that you will expect in a natural history of a patient with MAFLD, not chronic hepatitis B alone, but with MAFLD. Because if you can see here, cardiovascular events and malignancy, we're not talking just about HCC here, also other extrahepatic malignancy is also equally high. And what is also important is the fact that this is also related or leads to all-cause mortality in these patients. So I'm not going to make comparisons between those with advanced fibrosis or versus those without advanced fibrosis. Suffice to say that these outcomes are quite real and expected. If you look at liver-related complications, it's definitely going to be higher amongst those with advanced fibrosis compared to those without advanced fibrosis. But if you look at the cardiovascular event, which is the commonest cause of death in patients with just pure MAFLD or fatty liver disease alone, not to say that they have with chronic hepatitis B, you can see that having cardiovascular events is actually important, not just in those with advanced fibrosis, because it's not related to the fibrosis, but the presence of steatosis. So how real is this cardiovascular outcome? And I will show you some data later. But just coming back to this study alone, so what it shows in here that advanced liver fibrosis is independently predicted, not just independently predicting the liver-related complications, also the overall mortality and the combination of the events, which is labeled here under the composite endpoints. Okay, so the key messages from the combination of having concomitant chronic hepatitis B and fatty liver disease is that there is definitely higher likelihood of developing advanced fibrosis, and this advanced fibrosis is the strongest predictor of liver-related outcomes and also overall mortality in patients with chronic hepatitis B. And the third thing to take note is that in addition to controlling the viral suppression or the active viral replication, it is also important to control the fatty liver disease and control the steatosis to reduce the risk of fibrosis progression in these patients. So another study that he actually published together is look with the team, and I believe Dr. Yong is also part of our audience here, is looking at the inflammatory markers. And here, again, what I would like to highlight is the conclusion from in the abstract shown that the presence of metabolic syndrome and chronic inflammation, as shown by these inflammatory markers here, actually were two independent factors that lead to progression of liver fibrosis or cirrhosis in these patients. And I think here, highlighting on the multivariate analysis is not just the CAP score, which is the reflection of the steatosis severity, also diabetes and platelet count, but independently associated with presence of advanced liver fibrosis. So before I end, I'll just highlight again what Dr. Arifuddin has actually mentioned, that the real need for a new nomenclature is not so much to actually say that one is better than the other, but I think one of the main things out of the MAFLD of focusing on the metabolic dysfunction associated steatotic liver disease is the presence to have a lower threshold to include at least one of the 5 cardiometabolic risk factors. And this is what I had alluded to earlier, that the studies and from this meta-analysis shown on the right showed that you are at least 45, there's at least 45% prevalence in this study of having coronary artery disease in patients with steatosis. And it's not based on whether or not you have fibrosis, but just presence of the steatosis alone, which is an independent risk factor of developing major adverse cardiovascular event. And just to remind everyone, the highest cause of death amongst patients with fatty liver disease is not from liver, but from cardiovascular as well as malignancy, including extrahepatic malignancy. So here I'd like to remind everyone what are the cardiometabolic risk factors, and the emphasis amongst those who are actually these risk factors are really and independently associated with cardiovascular events. So not just being overweight, but having a central obesity. So the waist circumference is a lot more accurate in predicting those at risk. So it's not just having diabetes, but if you have insulin resistance and even having a pre-diabetic profile also makes it important. And amongst the dyslipidemia, it's not cholesterol, it's so much as in the triglyceride, and having reduced HDL, having this risk of having cardiovascular disease. Hypertension is also one of the risk factors highlighted here. What Dr. Arifuddin has shown is the importance of fibrosis stage in predicting liver-related mortality. But a more recent study, and that study by July is a retrospective study, but a prospective study had shown that it is only when you have fibrosis stage 3 and 4 that makes a marked difference, and the reason of actually picking up advanced fibrosis or cirrhosis or F3 or F4 to predict those with highest risk of death, but also highest risk of developing HCC. So really, it is fortunate that the type 2 diabetes guidelines had included not just the screening for fatty liver disease, but also the liver disease stratification among patients with type 2 diabetes. But it should not be restricted to only type 2 diabetes. As for EASL guidelines, it should include everyone with a metabolic risk profile that should be screened for fatty liver disease. So here is the guidelines, a table summarizing that you first need to screen using either the liver enzymes of ALT and AST, but ultrasound is also an easy way to pick up, and most are picked up incidentally to actually look at the presence of fatty liver disease. But I think what is a lot more important is including the FIT4 scoring to stratify the liver disease severity in the CPG under management of type 2 diabetes. So as most of you are aware, the FIT4 consists of 4 parameters: age, AST, ALT, and platelet count, and easily done and can be optimized further in many settings, especially in primary care and GP setting. What I would like to highlight is also something from a practical perspective. The CPG has mainly actually looked at whether you have FIT4 less than 1.3 or FIT4 of more than 1.3. I mean, here, from a practical standpoint, if you look at the actual numbers like we did in our study, you're going to be referring more than 50% of patients with FIT4 of 1.3 to the tertiary setting if you do that. So what I would advise is, rather than look at whether less or more than 1.3, look at the actual score of FIT4. Look at the value, because the value can predict a lot better those who should be referred, who must be referred. So if you have value, a higher cutoff of 3.25 in this study, you are going to predict those who are likely to have advanced fibrosis, and these are the patients who should be referred, not just for the further management of advanced fibrosis. So they will also have to be managed from the point of view of varices surveillance, because some of these patients are already going to be cirrhotic. Another is, as shown on this slide, the value of FibroScan. What Dr. Arifudin was highlighting in the second case, is it still worthwhile, knowing that the patient is cirrhotic, to do a FibroScan? The answer is yes, because we can use the Baveno 6 consensus to do a non-invasive assessment whether or not this patient have clinically significant portal hypertension. I won't go into the details, but looking at the platelet count together with the liver stiffness measurement can help you identify those who are likely to have clinically significant portal hypertension, and these patients should be on carvedilol if there are no contraindication to reduce the risk of CSPH. And lastly, we also should look at the opportunities, because virtually everyone you diagnose to have fatty liver, especially if they have elevated ALT and AST, must also have exclusion of other common liver disease, especially Hep B and Hep C and alcohol excess. So you are also picking up those who may be at risk of having HCC by doing this as well, and picking up other forms of liver disease. They may have the two together, like our patient. So thank you very much for your attention, and I hope that you help me to actually do the survey, or rather the feedback forms later, and I'll just get everyone to actually fill in the form if you have time to do this, while I'll wait for questions. Any questions? And maybe I'll get my team, Dr. Najmi or Dr. Gary, if you have anything to add, not just on the cases, but maybe lessons learned, or what are the key things that we actually have to highlight to everyone present. Dr. Najmi, go ahead.
Good afternoon, Prof. Thank you, Dr. Arif and Prof. Rose for the presentation and discussion. I have nothing much to say, but I just want to give a bit of data. Actually, we have done a very small retrospective study in 2020, if I'm not mistaken. The prevalence of MAFLD at the time in patients with chronic hepatitis B. So we went through about 201 adults with chronic hepatitis B, and at that entry point, we have about 15.9% chronic hepatitis B with fatty liver.
59?
But event 15.9%.
Oh, okay, that's quite low. Yeah.
But that's at the initial entry point. But throughout the 9 years, in total, that's mean new plus pre-existing MAFLD or NAFLD in chronic hepatitis B, total overall would be 33.8% of chronic hepatitis B patient with concomitant NAFLD. And when we went through the 9 years follow-up, we found that I mean, when we compare between chronic hepatitis B with or without MAFLD, of course, in hepatitis B with MAFLD, they have higher fibrosis score, 9.8 versus 7.3. And then in terms of during the follow-up, about 41% of hepatitis B develop new diabetes, and 3% of them develop new dyslipidemia, and actually about 11% of them progress to cirrhosis.
Wow. Okay, I think that's significant, and I think it's important for us to not just focus on hepatitis B, but also the metabolic risk factors and get them to be controlled to reduce the progression. Thank you very much for sharing that. Did you by any chance have also samples, blood samples on this patient?
We compare between Hep B alone with Hep B with MAFLD, and they in the one with Hep B and MAFLD, they do have a higher ALT, although still within the hospital normal limit. The value was 48. This is for ALT, 48 versus 33 ml.
So perhaps we can actually have further discussion on this, because we may actually can look at the inflammatory markers as well, and we can actually collaborate with Dr. Yong on this aspect. Thank you. Gary, anything to add?
I think all well covered, no, Prof. I think nothing much to add.
Is your impression the same as mine? We are seeing a lot more people with both diseases, especially amongst the elder age group. The answer is actually yes, because I actually marked all my patients hepatitis B with the ones with concomitant, and it seems that definitely we are saying at least half of them has got both together. So I think that's what we have to be on the lookout for, not just assess our hepatitis B from the viral replication, the liver disease aspect must be looked at, whether there's any concomitant MAFLD as well. Okay, I don't see any questions in this here, and if not, we'll thank Dr. Arifuddin again and thank my team for always willing to share our cases together, because I think it is not extra effort to do that, and I hope everyone can volunteer and can contact me if you do have cases that you want to discuss, and I can also help with the presentation. So please allow time to actually do the feedbacks, and our next presentation I will actually include in our iEcho platform will be next week by the team from SGH, Sarawak General Hospital, by Dr. Victoria Cox's team, and we will actually have a discussion on alcoholic liver disease. So thank you again, everyone, and have a good day.
Thank you, Prof. Thank you, everyone.
Thank you, Prof. Thank you, everyone.
Thank you.